go to the presentation. Thank you so much. This is a presentation outline. Okay, first I will talk some introductions on ECG, particularly in pediatrics, the difference between pediatrics and adult ECG, and in subsequent slides, I will give some examples pictorially on abnormal ECG in pediatrics. Okay, as introduction, ECG is a non-invasive diagnostic tool that measures electrical activity of the heart. So we put electrodes on the chest, that's pericardium, and also on the limb to measure the electric current in millions of myocytes, which are depolarized in synchronous fashion. And ECG was first invented by William Einthoven on 1902, and he was awarded Nobel Prize for this important medical invention in physiology. And ECG is very important in diagnosing as well as managing heart condition in pediatrics. And as it is available or easily available everywhere, compared with other diagnostic cardiac tools like echocardiography, so ECG can be used by nurses or other clinicians in order to have first insight into cardiac problem in children. And it can help us to understand the structure as well as function of heart condition. So if there is abnormality in ECG that may show structural or functional abnormality in the heart or other pathologic conditions which result in this abnormality, which need further investigations in order to reach out conclusive diagnosis. And emergency physicians or all clinicians use ECG for a variety of reasons, including monitoring of critical patients in real time so that problems in cardiac rhythm, heart rate can be picked early, and so that intervention can be done earlier, with, which can improve the prognosis in overall patient care and outcome. And as you know, congenital heart disease is the most common birth defect, which affect around 1% of all live births in the world. So if we can use ECG in the neonatal ICU, we can pick this congenital heart disease so that early intervention can be done or management can be started. And the impact of heart conditions generally depend on the type and severity of the defect, and some defects may be minor and cannot have or cannot show any abnormality on ECG. So we need to depend on physical findings, on the history, clinical history of the patient, as well as other diagnostic tools which support in diagnosis of these cardiac problems. And the incidence of arrhythmia is very high in children with congenital heart disease, and this arrhythmia can be due to abnormal anatomy or displacement of the sinus node or AV node, or there may be abnormality in conduction system, abnormal hemodynamics, or primary myocardial disease like in dilated cardiomyopathy as well as hypertrophic cardiomyopathy. And there may be hypoxic tissue injury, residual post-operative sequelae. So if patient has CHD and surgery is done, still the patient is at risk of developing arrhythmias or ECG abnormality. And there may be some genetic influences that can result in arrhythmia in those with CHD, like long QT interval. And let me talk about essential cardiac electrophysiology. So when we talk ECG waves in ECG leads, we are talking about millions of myocardium, which are picked by the electrodes, and these are waves of depolarization and repolarization of myositis. When we say a cell is fully repolarized, that means it is in resting state and it is negative inside and positive outside. And when there will be onset of depolarization spontaneously in the SA node, there will be shift of positive ions into the cell, that is sodium, and there will be waves of depolarization. And when cell is fully depolarized, it will contract, and after that, there will be onset of repolarization in which these positive cells shift to outside, and then cell will be fully repolarized in resting phase. That means the myocardium is relaxed. And this wave of depolarization and repolarization will be recorded on ECG, and there will be deflection, positive deflection, and negative deflections on ECG. And this is determined on the direction of wave of depolarization and repolarization. So if there is wave of depolarization, which is moving toward the positive electrode, we will get positive deflection on the ECG machine or on the leads, and as the opposite is true. And if there is wave of repolarization moving to the repolarization moving toward the positive electrode on the pericardium or on the limb leads, will get negative deflection. And this is a further pictorial presentation of this wave of repolarization and repolarization on the ECG. So if there is a wave of depolarization toward the positive electrode or positive electrode pad on the chest, that will be deflected as positive wave or upward on the ECG. And if the wave of depolarization towards the negative electrode, that will give us downward deflection or downward wave on ECG leads. And in wave of repolarization, if there is wave of repolarization toward negatively, that will give positive deflection, and the opposite is true. When there will be wave of repolarization toward positive electrode, that will give negative deflection or wave on the ECG leads. And we see heart from different angles when we evaluate electrical activity of the heart by ECG. So we see the heart as three-dimensional. We put the electrodes on the pericardium and other electrodes on the limbs that can be put proximally and distally, particularly put proximally the limb leads in pediatrics in order to decrease artifact from the movement. And these all leads electrodes will give ECG lead readings, and in pediatrics we use additional leads, particularly V4R, that will be placed opposite to V4 on the left pericardium, and that will give additional information about right ventricle, which usually have abnormality in young children, particularly less than 5 years. And in young infants, where there is physiologic hypertrophy of the right ventricle. And this is pictures to show where we can put the limb leads, limb electrode, sorry. So this is the right arm and this is a left arm. So we put right limb electrode on the right arm, and that can be placed on proximal arm or at around shoulder in pediatrics, and the left arm electrode can be put here or on proximal extremity in pediatrics, and on right leg, that it is colored, the white is put on the green is put on right leg, and the red electrode will be put on the left leg. And this limb leads view the heart in vertical view. That means we'll see or the ECG electrodes will report how electrical activity is on the left-right direction or up-down direction. And this is how chest electrodes are placed. We put the V1 in fourth intercostal space, right to precordium, and V2 on fourth intercostal space, left to precordium, and V4 will be put on mid-clavicular line on fifth intercordium, and we put V3 between the two. That means between V2 and V4, and V6 is put on the mid-axillary line, left mid-axillary line, and we put V5 electrode between V6 and V4, and additionally we put V4R in order to evaluate the right ventricle activity electrically on the left side opposite to V4. So this chest leads or precordial leads will give the chest view on posterior anterior, or it records the posterior anterior electrical activity of the heart. So considering 360 full circle, these are the direction in which the limb leads detect the electrical activity of the heart. And lead 1 will record electrical activity, making the right arm negative and the left arm positive, so it will be at 0 degree. And lead 2 record electrical activity, making the right arm as reference and the left leg or the legs as positive electrode, so that the deflection will be, or the vector direction is 60 degree. And in the lead 3, that will be 120 degree. And we have 3 augmentary leads which are created by the ECG machine by taking the one limb as positive and the other as reference. To take as an example, in AVR, the right arm will be positive, and the other arms, the left arm and the leg will be negative, so that the direction or the vector of AVR will be 150. And these limb leads will help us in determining the axis of the heart, the QRS axis. So if the axis can, whether it is deflected to left or right axis deviation or left axis deviation, and where the normal axis is between 30 and 90 degree, it varies with age. And usually in pediatrics, the normal in the early infancy, the axis will be normally there will be right axis deviation. That means it will be in this quadrant. And this axis determination also will help us in determining whether there is chamber hypertrophy or not. I will discuss this in subsequent slides. And depending on whether the electrodes are placed, it will show whether there is abnormality in specific chambers of the heart. For example, we put V1 on the right of sternum enforced intercostal space, so it will give us information or electrical activity of the right ventricle, and V2 and the V3 will represent the interventricular septum, and the V4 will be around the apex, so it gives electrical activity of the apex of heart, and V5 and V6 will show electrical activity of lateral part of left ventricle, and this chest leads gives information about electrical activity of the heart along the limb leads. So V1 and V2, AVR, sorry, gives electrical activity of the right ventricle. So there will be abnormality in these limb leads, augmented limb lead AVR or chest lead V1 if there is abnormality in right ventricle. And lead 3 AVF and lead 2 will give if there is abnormality in the inferior surface of the heart. And on ECG paper, there is time interval which will be recorded on the x-axis, and voltage which will be recorded on the y-axis. And this recording represents the electrical activity of myositis, and we don't see electrical activity of the SA node, the pacemaker, and the transmission through the conducting system, as there will be no sufficient voltage to be displayed on the ECG leads. And durations are recorded in fraction of seconds, and amplitude are recorded in millivolt, and there will be configurations, that means the waves of the ECG that can be upward or downward, and we need to study the shape and appearance of these waves. And this is standard ECG paper. So the small box is 1 millimeter by 1 millimeter square, and in horizontal axis, x-axis, it records the time. So it is 0.04 second, or that means 40 millisecond, if the ECG paper speed is 25 millimeter per second, and the voltage is recorded in standard ECG as 10 millimeter equal to 1 millivolt. So 1 millimeter will be 0.1 millivolt in standard calibration. And this calibration can be changed there may be half calibration, or it may be doubled, and the ECG paper speed can be also 50 millimeter per second. So in interpretation of ECG, we need to use this standardization while determining the voltage of the waves, as well as in order to calculate heart rate. So when we read ECG, we need to see the intervals as well as the waves and the segments of the ECG display. And the first wave is the P wave, and it shows depolarization of the atrium, and then there will be PR interval where it shows delay in the AV node before the QRS, which is ventricular depolarization, and usually this QRS duration less than 0.1 second. And after QRS, there will be a wave of repolarization of the ventricles, that is a T wave, and usually it will be deflected in the direction of the QRS, and this amplitude will be 1/3 to 2/3 of corresponding R wave. And the other is QET interval. When you say QET interval, it includes both QE wave as well as T wave, starting from onset of the QE wave to end of T wave. that encompass the time from ventricular depolarization to also including the ventricular repolarization. So here we can see what I've shared you in the above slides. So the P wave shows the arterial depolarization, which is starting the SA node in the right atrium and move in this direction. So that will be deflected positive, that will lead to, and there will be PR segment, the delay between the arterial depolarization to ventricular depolarization, which allow the ventricular filling during the systole period, and then will be ventricular depolarization that will be represented by the QRS complex, and afterwards there is ST segment, and then T waves, which shows ventricular repolarization or relaxing of the myocardium. And R interval is taken as 1 beat. And it is important to screen infants, children, and teenagers, particularly if there is history and physical findings like chest pain, syncope on exertion, if there is family history of sudden cardiac death, if there is history of palpitations, and if there is irregular heartbeat on physical finding or murmurs, we need to screen infant or other pediatrics groups for some rhythm abnormalities, or that can help us also to give us insight if there is congenital, undiagnosed congenital heart disease, and this can help us in preventing sudden infant death syndrome, which may be associated with some rhythm abnormality which result from channelopathies. And when we approach ECG interpretation, there are steps we should follow in all ECG interpretations. First, we need to see the calibrations and the speed of ECG paper, whether it is standard or not. Then we will, second is the rate, okay? When we determine the rate of rate on the ECG paper, it depends on the speed of ECG paper. If the speed of ECG paper is 20 millimeter per second, we can divide 300 by amount of big squares between the RR intervals. And if the rhythm is abnormal, we can count the RR intervals. That means 1 beat between 13 seconds. We can count in 10 seconds, in 6 seconds, then multiply that in order to get heart rate. So if you count RR intervals, 5, or if you count 9 RR interval in 10 seconds, so we multiply that by 6 in order to get how many heart beats in 60 seconds. And the second is rhythm. So the rhythm may be regular or irregular. So that depends on the RR interval. So if the RR interval is regular, that's regular rhythms. And the rhythm may be irregular. So that may be regular irregular, or it may be regularly irregular. So that's abnormal rhythm. And next step is determine the axis, whether there is left or right axis deviation. There are different methods in which axis can be determined. One is quadrant method, which is more simple. We use lead 1 and AVF. So always, in order to determine the axis, we need to use limb leads. So lead 1 and AVF can be used, which are perpendicular to each other, and that can help us in order to determine the axis, whether there is right or left axis deviation. The other is we can use additionally lead 2 in order to determine determine the axis. And the third method is to use isoelectric line, and then we can use the most positive limb leads in order to determine the axis that will be 90 degrees to the isoelectric limb lead. And the fourth step is intervals. So we need to see the PR intervals. We need to determine whether it is constant or there is variation, whether it is normal or abnormal depending on the age of the patient, as well as QRS intervals and QVT intervals. It should be standardized for pediatrics. There is a standardization table. I will show that in subsequent slides. And we need to see the waves. So we need to see the P wave. P wave, as I said, it shows depolarization of the atrium. So that means left and right atrium. Right atrium will be depolarized normally first, as is noticed in the right atrium near to superior vena cava. So the first half of P wave shows right atrium depolarization, whereas the second part will show left atrium depolarization. And if there is peaked P wave, that means there is left atrial enlargement. If the P wave is bifid or it is broadened, that means there is a left atrial enlargement. And other next step is QRS complex, which shows ventricular depolarization. Again, we need to see the amplitudes, and we need to standardize for age and as well sex of the patient. And we need to determine also its duration. Usually it is less than 0.1 second, that means 100 millisecond. So we need to standardize, of course, for age of the patient. And the next step is ST segment evaluation and T wave evaluation. So we need to compare the ST segment with TP segment, which is considered isoelectric line, as heart is in resting phase on the TP segment. So you need to compare ST segment with TP segment to determine whether it is elevated or depressed. And you need to see also next the T wave. Usually it is broad. And you need to see whether it is up deflected or down deflected, as well as you need to see the amplitude. And there are age-related changes in pediatrics patients. One is, as you know, the heart rate of the young children are high. So we need to understand that, and that should be interpreted based on age of the patient. And normally the P wave of pediatric patient is small. Usually it is less than 3 millimeter. And its duration is also short, usually less than 0.09 second in children, and in young infant less than 0.07. And also QR axis normal deviated to the right. There will be normal or physiologic right axis deviation in young infant, and which will resolve at the age of 6 months. As I said earlier, there is a dominance of the right ventricles physiologically. So that will change as a child grows and the left ventricle become dominant. And the PR interval is also short in pediatrics compared with adult, as there is a less degree of muscle mass. So we need to, of course, standardize for age of the patient. And normally during the first 7 days of life, T wave is typically upright or it is deflected upward, and downward deflection will occur after age of 6 years, and it may, of course, persist up to adolescent. So in the first 7 days of life, we expect normally upward T wave in normal ECG of neonate. And the amplitude of T wave is usually between 1/3 to 2/3 of corresponding R wave. And the interpretation of ST segment is similar to adult, so it depends on comparison between the TP segment and the ST, so we can determine if there is elevation or depression, which will give us insights, or it may show some pathologies if there is this ST segment elevation or depression. And the other wave is U wave, which follow T wave, and usually it is normal, particularly if there is sinus bradycardia, and it may show abnormalities like electrolyte changes or low level of potassium or hypokalemia. And this picture is to show the T waves. Here in the first picture, this is a picture of 1 month infant, and it is upward deflected, so that's normal. And second is T wave in 3 years old. It is downward deflected, and that's normal. Again, it will be upward deflected in after adolescence, so it's a normal wave of T wave on ECG. And the other wave is Q wave. That's the first downward deflection after P wave, and normally it is narrow, and its duration is around 0.02 second to 0.03, and its amplitude is around less than 5 millimeter, and it may reach 8 millimeter in limb 3 in those younger than 3 years. And if there is abnormality in Q wave, it may show different heart pathologies. And if there is Q wave in right recorder lead like V1, it shows severe right ventricular hypertrophy. And if it is absent in left precordial leads, it will show pathologies like left bundle branch block. And if there is abnormally deep Q wave in left lateral leads like lead 1, AVL, V5 to V6, that will show hypertrophic cardiomyopathy, which mainly affects the left chamber. And if there is abnormally deep and wide Q wave, that show myocardial infarction or fibrosis. And this is table which can be used in order to standardize ECG based on age of a patient. So these are the standardization. So heart rate, QRS, QT interval duration, PR duration, R wave duration, S wave, and Q wave. That's very important. And there are some common ECG patterns in pediatrics heart conditions or heart abnormalities. And the commonest one is sinus tachycardia. It is very common in children and can result from fever, anxiety, pain, anemia, or exercise. And on ECG, if there is sinus tachycardia, there will be normal sinus rhythm with increased heart rate. So there will be P waves before every QRS complex, and also the duration of PR interval remains constant. That is sinus tachycardia. And always the QRS complex is preceded by P wave. And in sinus bradycardia, there will be normal origin of the rhythm from the sinus node, but there will be slower discharge of this electric impulse from the SA node, which may be normal in athlete or during sleep. And that can also may result from pathologies like hypothyroidism. And on this ECG leads shows there is sinus tachycardia. The heart rate is roughly around 150 as the interval is regular, RR interval is regular, and there is 2 large squares, so we divide 300 by 2, that will be 150, and there is P waves preceding every QRS complex. So this is sinus tachycardia, and in sinus bradycardia, there will be low heart rate for age, and there will be P wave before every QRS complex. So these are the P waves we can see from the ECG leads, and the heart rate is approximately, we can see 1, 2, 3, 4, 5, 6 big squares. So dividing 300 by 6, that gives the heart rate around 50. So in 25 millimeter per second ECG standard, that means there is bradycardia. And the other ECG abnormality is supraventricular tachycardia. It is common arrhythmia in children, and it is characterized by episode of rapid heart rate originating above the ventricles. That means at bundle of his or above it. And the ECG pattern during SCVT or supraventricular tachycardia is typically shows narrow QRS complex, and there will be rapid heart rate in infant around 220 to 300 beats per minute, and in older children around 150 to 250 beats per minute. And in this ECG pattern, P wave may be difficult to distinguish during the tachycardia. And the other ECG abnormality is ventricular tachycardia. So this ventricular tachycardia is abnormal rhythm originating from the ventricles. So there will be discharge of electric impulse from the ventricles that will result in a ventricular tachycardia. And in case of ventricular tachycardia, the QRS complex will be wide, and the beats is usually above 120 beats per minute. And also we may not identify the P waves, which shows the arterial depolarization. And in this first picture, we see narrow QRS, and there is rapid heart rate, and there is no clear visible P wave, so that is supraventricular tachycardia. And in the second picture here, we see there is wide QRS and rapid heart rate, and no clearly visible P wave, so that is ventricular tachycardia. And this feature also may present with supraventricular tachycardia with bundle branch block. But in case of supraventricular tachycardia with bundle branch block, there will be less P waves, more P waves compared with the QRS. That means the arterial rate will be equal or more than the ventricular rate. That will can help us in differentiating if there is wide QRS with supraventricular tachycardia. And the other abnormality, ECG abnormality, is arterial fibrillation. It is rare in pediatrics, but it can occur if there is underlying health conditions like mitral stenosis. And in arterial fibrillation, there will be discharge, electrical discharge from different part of atrium, and so the arterial fibrillate, and there will be irregular response of the ventricles. So the RR interval will be different for all beats, and there will be no discrete P waves. And in long QT syndrome, which is inherited disorder, there will be prolonged QT intervals for age and sex of the patient, and this long QT interval will predispose a child to ventricular fibrillation, which can result in life-threatening arrhythmia called torsade de pointes, which can result in sudden cardiac arrest. And this is a picture to show atrial fibrillation. So these are the fibrillatory waves, and as you see, the RR interval is irregular, and there is no two intervals or RR intervals which are similar. And this is to show long QT interval. So you need to standardize for age and sex of the patient, as well for heart rate using Bassett's formula, as there will be short QT interval in tachycardia or increased heart rate, and longer QT interval in lower heart rate. So you need to use Bassett's formula, which uses QT interval in second divided by square root of the corresponding RR interval. And the other disorder, rhythm disorder in pediatrics, is Wolff-Parkinson-White syndrome. In this case, there will be accessory pathway called bundle of Kent, which can lead to supraventricular tachycardia. And on ECG, as there will be no delay at the AV node, there will be short PR interval, and also we see delta waves, which is slurred upward deflection of the QRS. And this is abnormal ECG in 1 week old, normal ECG in 1 week old neonate. As you see, there is right axis deviation. The QRS axis in V1, in the lead one is negative, and in AVF it is positive. So the axis will be on the right quadrant, or there is right axis deviation, and the axis around 125. And this is normal in the young infant. But if this is ECG of 4 or 5 years or older children, that shows right axis deviation, which indicates right ventricular hypertrophy. And this is ECG of neonate with tricuspid atresia type 1. And you can see there is right axis deviation. And as I said earlier, there is right side dominance in neonate. So if there is right axis deviation, that is abnormal. So that may show there is no right ventricular dominance, which is associated with tricuspid atresia. And additionally, on this ECG, there is peaked or increased the amplitude of P waves, which shows right atrial enlargement. And also it shows left ventricular hypertrophy. As you see, there is deep R wave in V1, V2, and V3, and deep S wave, and deep increased amplitude of R wave in the in V6, which shows left ventricular hypertrophy. And this is ECG of 10 years old with primary pulmonary hypertension. And we can see there is tall R waves in the right precordial leads in V1 and V2. And S wave is deep in V5 and V6, which again supports right ventricular hypertrophy. And this is ECG paper of 3 years old with coarctation of aorta, which result in left ventricular hypertrophy. As you see, there is deep S waves in V1 and V2 and taller waves in V6 and V5. So it shows left ventricular hypertrophy. And this is ECG paper which shows premature ventricular contraction waves, which is interspaced with a normal QRS complex. And this is ECG of an infant, and it shows RS prime pattern, and which suggests right ventricular conduction delay or bundle block. And there may be a blockage of the impulse propagation in the bundle office. There may be left or right bundle branch block. And if there is bundle branch block, we'll get widened QRS complex, usually greater than 120 millisecond in both right and left bundle branch block. And in left bundle branch block, there will be dominant S wave in V1, and we'll get broad monophasic R wave in lateral leads. That means in lead 1, AVL, and V5 and V6. And there will be absence of Q wave in lateral lead. And there may prolonged R waves peak in V5 and V6. And in right bundle branch block, there will be R prime pattern in V1 to V3. And that will show rapid ears appearance, and there will be slurring of the S wave in left lateral leads. And this is a picture to show left bundle branch block. You see in AV left lateral leads, there will be broadened even bifid R wave. And in the right bundle branch block, there will be R prime pattern in the right precordial leads, including AVR, V1, V2, and V3. And this also another picture to show right bundle branch block. There is, as you see, there is R prime pattern in V1 and V2. And the other abnormality we see on ECG is ventricular chamber or chamber enlargement generally. And if there is right ventricular hypertrophy from different pathologies like pulmonary stenosis, primary pulmonary hypertension, or from conditions which affect the left chamber like mitral stenosis, which result in pulmonary hypertension, can give us right ventricular hypertrophy. And if there is right ventricular hypertrophy, there will be right axis deviation and taller wave in the right side leads. That means V4R and V1, and deep S wave in the left-sided leads on V5 and V6. And there will be increased RS ratio in right precordial leads, that's V1 and V2, and RS ratio will be less than 1 in V6. So there is deep S wave. and there may be upright T wave in V1 and V4 in children 3 days to 6 years, in which we expect normal downward deflection. And if there is also QR pattern in V1, that's also very highly specific for right ventricular hypertrophy. In this ECG paper, we can see there is tall R waves in V1, V2, and V3, and there is also right axis deviation. As you see, there is negative KRS pattern in lead 1 and a positive pattern in AVF. So the axis will be, there will be right axis deviation, which suggests right ventricular hypertrophy. And in left ventricular hypertrophy, there will be left axis deviation and tall R wave in left pericordial leads. That means V5, V6, and deep H wave in right side leads, V4R and V1. And we need to compare this amplitude, or we need to standardize for age of the patient, and also abnormal RS ratio, which favor right ventricular hypertrophy. So it will be high in left pericordial leads, and it will be decreased in the right pericordial leads V1 and V2, and there will be inverted T waves in lead 1 and AVL. So in this picture, we see there is deep S waves in V1, V2, and V3, and there is left axis deviation, which suggests left ventricular hypertrophy. And the other heart conditions in children is heart blocks. That means there will be sluggish impulse transmission, or totally the impulse from SA node or the atrial node conducted to the ventricles. And depending on the degree of block, that can be first degree heart block, in which all atrial impulse will be transmitted to the ventricles, but there will be increase in the PR interval. That means we have P waves before every QRS complex, but there is delay in transmission of this impulse. And in second degree heart block, which is divided into two, Moptis type 1 and the Moptis type 2. In Moptis type 1, there will be increase in the PR duration, and then there will be drop in QRS. And in Moptis type 2, there will be constant PR interval, but there will be drop suddenly in the QRS. And in the third degree heart block, there will be no transmission of impulse from the atrium to ventricle. So there is no relation between the P and the QRS. That means atrium and the ventricle beats independently. So there is no pattern which, in order to associate the P wave with the QRS. And if there is abnormality in electrolytes, we may get some ECG patterns, but these ECG patterns are not specific to these electrolyte imbalances. So we need to confirm whether there is electrolyte abnormality which give us these ECG patterns. And the common electrolyte imbalance we encounter in clinical practice is one is potassium abnormality, hyperkalemia or hypokalemia. If there is hyperkalemia, particularly mild to moderate degree of hyperkalemia, there will be peaking of the T waves. And as the degree of hyperkalemia increase, there may be widening of the QRS, and also there may be delay in or increase in the PR interval. And if it is severe, there may be, it may result in sine waves, which is presented on this ECG. And in hypokalemia, we'll get abnormality in repolarization, and usually there will be U waves following T waves if patient has hypokalemia. And in patient having calcium abnormality, which affects the Asst segment early, so in hyperkalemia, there will be shortening of the segment.
How much?
Sorry?
150.
I am finishing.
You go find out.
Okay, I'm finishing this final slide. I'm left with 1 or 2 slides, sorry.
Bring her.
Sorry?
Okay.
Can everyone mute, please, so that, please remain muted. I mean, thank you. Sorry, Dr. Nigatu, you can proceed.
Okay, okay.
Thank you.
So in hypocalcemia, there will be prolongation of Asst segment, and there may be also abnormality, other abnormality, ECG abnormality, which depend on degree of hypercalcemia and hypocalcemia. And there are some ECG patterns which are normal in pediatrics. One is the heart rate, usually in adults, the normal is less than 100, 60 to 100. So in young infants, the rate may be normally higher. And there may be apparent right ventricular stream pattern. So there may be T wave inversion in young children. And as I said earlier, there may be normal right axis deviation in young infants. So dominant R wave in V1, and also RSR pattern in V1 may be normal. And there may be normal also sinus arrhythmia, and the PR and QRS duration may be also short. And there may be slightly peaked P wave, and there may be slightly prolonged QTC or corrected QT interval in a young infant, which may reach 490 milliseconds. And ECG can help us in treatment and management of different conditions and diagnosis, in monitoring during treatment and after treatment, risk stratification, particularly in sport participation, in medication management when we may administer medication which affect heart rhythm. So we can use ECG in order to monitoring, and also it may guide us in procedures like catheterization, heart catheterization, and also it can help us in telemonitoring, so we can monitor the rhythm of a patient by recorded Holter monitoring. And if there is risk, particularly if patient has some cardiac abnormalities, so we need to perform ECG, and if time permit or the condition is not emergency, that may need correction of this ECG abnormality based on underlying cause before surgery, and ECG can help us also as screening tools. And this ECG should be complemented by other investigation tools in order to reach at conclusive diagnosing some cardiac abnormalities, as shown this snapshot of heart activity, and there may be also false positive or negative ECG patterns from different factors. And as I said, we view only the heart from certain angles. So there is limited spatial resolution, and ECG may not differentiate between hypertrophy and dilatation. And these are my references, and thank you so much. I finished my presentation.
Thanks you very much. Can you hear me?
Yes, yes.
Yeah. Thank you, Dr. Nigatu, for the good presentation about the role of EKG in diagnosing and management of the children conditions. This is among the best presentation, and I think that it has been recorded so that to know how to read the EKG is somehow difficult, but when you revise the note, it will be helpful. So now it is the time of question or comment. Then we welcome anyone who has question or comment. But first of all, we have the question in the chat box from Alexi Guanyange. Why are children under 1 year are having high risk for SDS on prone position?
Sorry, would you repeat the question?
Yeah, the question is on the chat box. Why are the children under 1 year are having high risk for SIDS on prone position?
For S?
SIDS.
DS.
Yeah.
Sorry, what's the abbreviation stand for? Sorry, to make the question clear.
So, Guanyange can help us. What did this abbreviation stand for?
Yeah, that's good.
Is Alexis connected? Can you let us know what's SIDS, please? I think it may not be a universal abbreviation or something. Alexis, what's SIDS?
Sorry, can we proceed to other questions before he responds?
Yeah, I can proceed for the other question.
If there is other pending questions.
So I have one question.
Okay.
About the EKG.
Okay.
Sometimes when you do the EKG, there is a time that you can have the artifactors.
Yes.
So what are the things to avoid so that you can avoid to have those artifactors?
Okay, it is okay. So in order to avoid artifacts, one important thing is positioning of the electrodes, and we need to attach the electrode pad to surface of the correctly, as well as you need to if there is hair, it should be removed, okay, before the procedure. And if there is also movement, that can give us artifact, which can bring difficulties in the interpretation of ECG. And as I said in the presentation, limb leads can be put proximally around shoulder in young children, which may move during the ECG taking procedure.
Thank you. And for that question that you have stated before, we have seen that abbreviation that stands for sudden infant death syndrome.
Okay.
Yeah.
Sorry?
That question of Mr. Alexis, why are the children under 1 year are having a high risk for sudden infant death syndrome on prone position?
Okay, prone position.
Yeah.
So when we say sudden infant death syndrome, the cause may not be identified exactly, but prone position is considered as a risk. There is different studies which shows children, young infants who put in prone position. And in these young infants, there is increased sudden infant death syndrome for which there is no prior medical problems. And there may be obstruction, upper airway obstruction when infant is put in prone position, and that may contribute to sudden infant death syndrome. But we cannot actually directly correlate this upper airway obstruction associated with this positioning to sudden infant death syndrome.
Thank you. Another question on the chat: Can EKG only helps to reach on diagnosis for chronic heart disease, especially in resources limited area where there is no echography machine that can where there is no echography? Can you give us an example?
Okay, thank you. It may help us, but it is difficult to say to reach. It can help us at reaching a conclusive diagnosis. Particularly if there is extreme axis deviation, this is north-west axis deviation, it indicates AV atrioventricular septal defect, or there may be primum type of atrial septal defect. And if there is no right normal physiologic right axis deviation in young infants or neonates, that means there is no physiologic dominance of right side, so there may be right side heart problems like tricuspid atresia and other also important clue can be found from the ECG, but we cannot conclusively reach at exact diagnosis. So if there is ECG abnormality, that may result from organic cardiac problem or other systemic problems which can result in these rhythm abnormalities or the change in amplitude of the waves. So we need to further evaluate the patient, particularly using echocardiography. So that can help us particularly in screening. And it can also be augmented by the physical findings of the type of murmur that we can be having and other physical findings that can at least tell us if there is some congenital heart disease or congenital heart disease.
Thank you.
Okay.
Yeah, so it seems like there is no other question. So, as the chairperson of TORG, Education and Training Committee, my name is Anakeretu Saimana. I'm a nurse at University of Teaching Hospital Butare in Rwanda. Let me take this opportunity to thank you, but I'm gonna give the floor to the owner at the Bosora so that he can conclude. But we really take this opportunity to thank you for your time and this presentation of today that will guide us and will help to prevent some preventable death that can be caused by non-use of EKG, as we have seen how you can trace it, how you can interpret some abnormalities. Thanks a lot. Adebosora, the floor is yours.
Thank you so much, Anaclet. Thank you, Dr. Nigatu. Thank you for honoring our invitation. It was a short notice and you still made it in the end. I know you've got other commitments as well. I must say it was very, very technical and detailed, even beyond expectations as well. I think we might need like a hands-on practice or hands-on experience, something like that, so that everyone can really have a session. Even if it's coming to Ethiopia, we don't mind. So thank you so much for the detailed presentation and insightful presentation as well. because we had to change the time at a short notice, so some people weren't able to connect on time, even though they registered for the webinar. So we have it recorded. The replay is going to be sent and shared across our platforms. If you don't mind, if we could request for the notes or the presentation, you could have it tagged, have your name and everything on that as well. But if you don't mind, we could add it to, we could upload on the website and have it on the page where we have the replay, so that everyone can see that alongside, if it's okay with you only. And I would also like to say, we might bring you back for another session if you don't mind, just for a continuation, because I know it's very detailed and it's something that can't be covered in 1 hour, if that is okay with you. So I must say thank you so much for taking the time out of no time even to have a session with us to teach us in details about EKGs, ECGs, and correct interpretation of that, and the things to actually watch out for and see, especially in relation to pediatric patients. So thank you so much. And I also want to say thank you to the Education and Training Committee for organizing and facilitating this session. Thank you to everyone who connected from all over the world, and to those who are still going to watch the replay and see that on YouTube, either online or across our platform. So I say thank you to everyone. And I must say good morning, good afternoon, good evening, depending on your time zones. And we'll see you next time. Thank you so much, everyone. Bye.
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 Bye. Thank you so much. Bye-bye.
Bye.
Bye. Yeah. Bye, everyone.